Hello and welcome to Inside the Vault, a video podcast series interviewing some of the major leaders in our digital space. I am Jose Bolaños, MD, the host of this podcast, and I have two co-hosts, Eric Doherty and Eric Drew, and we're very excited to be bringing this presentation to you today. Dr. Dillon is a physician and digital transformation leader at HCA United Kingdom, specializing in integrating technology to optimize patient care and streamline healthcare operations. With extensive experience in both the NHS and private healthcare sectors, she focuses on digital transformation and health tech implementation in complex clinical environments. Dr. Dillon holds an executive MBA from London Business School and has been involved in various initiatives including mentoring and consulting on health AI, venture capital, and digital strategy. Good morning, this is Dr. Jose Bolaños, and we're bringing to you a brand new Inside the Vault interview of a major player in the space. Beyond the stethoscope, how the clinical leaders are driving the AI revolution in healthcare. And this is Dr. Angie Dillon, and we're going to be excited to talk to you. And I'd like, first of all, let's do some intros. Eric Doherty.
Jose, good morning. How are you doing? Hopefully doing well. Really appreciate the time on this. Again, my background is in healthcare. I'm the president and CEO of DPE International, which is a healthcare consulting group based in Atlanta, Georgia. And a lot of the work we do is with pharmaceutical companies, medical device companies, digital healthcare companies, really moving them through to commercialization. And I really enjoy having this topic as a key point for our discussion today.
Thank you. And my other co-presenter is Eric Drew.
Good morning, Jose. My name is Eric Drew. I'm a longtime patient advocate and advocate for different health initiatives. For the last 8 years, been working in AI and in clinical studies. So I look forward to this conversation. Thank you for having me.
Thank you. And we're so excited to bring in Angie Dillon, who is out of the United Kingdom with HCA. Please introduce yourself and let's begin a wonderful discussion.
Thank you, Jose. Hello, everyone. My name's Ikanjali Dillon. You can call me Angie on this episode. My background is that I am a physician by background. I still practice acute internal medicine and oncology. But some time ago, I transitioned into digital transformation leadership and med tech, health tech, scalability of it, the patient impact that I was able to achieve with it definitely got me very excited in the space. I mentor startups around that now and also sit on the board of a not-for-profit organization here in the UK called Age UK, Harrow Hillingdon Brent, and lead their AI and tech initiatives as well. So wonderful to be here. Hopefully I can provide a different, interesting lens. It's a little bit different on this side of the pond. And so hopefully it makes for a rich discussion.
Thank you. So one of the things that I was really interested in is that you trained in the United States and now you're in the United Kingdom. And obviously things are different from one to the other. Might you comment on what differences you have found in the delivery of care?
So I did actually train in the UK. I trained in the UK. I practiced in the UK, but England is wonderful because it's actually a very diverse terrain when it comes to healthcare. We have the NHS, a public healthcare system, which is the norm. It is under strain and has been for some time because of the sheer volume, but actually what we're delivering in the NHS is an excellent quality of care and free to all people of the country in terms of if you're a citizen. Then transitioning into private healthcare. So as you mentioned, I've been with HCA, I've worked for HCA clinically and now in digital transformation with them. And that's given me a different perspective. So the actual private healthcare industry here and in Europe is booming, it's expanding. And so that's provided a wonderful contrast and again, excellent patient care that we provide and really proud to be part of the organization.
Eric Doherty?
Yeah, I think one of the things that I found is just obviously there are differences in the nuances of rules and regulations between not only the US and UK, but the US and the EU in general. And so when it comes down to obviously HIPAA and things of that nature, where we're used to that in the US, a little different over in the UK. The other side of it is AI. There's a lot of new elements coming down the pike around rules and regulations on, how to use AI, where to use AI, and what's needed to be using AI. And so there are many, many, many differences between the two. They're similar in how they're being constructed, but there are differences between the two areas.
Thank you. Eric? Drew?
Yeah, so I think it's an interesting, difference and how are they going to apply those rules and regulations to all these, new, AI technologies coming down the pipe. I mean, obviously, it's been an issue. I told you I was working in AI and clinical studies for the last 8 years, and the biggest issue was access, right? It was access to that patient information, and without getting specific approval from each patient, how do you get access to those databases? And so I think that patients realize that they need to give access to their information in order to do that, but it's that permissive uh, regulation that we need to somehow figure out how that's going to be done. I mean, I think we've done a really good job both in the UK, in the EU, and the US, and in consolidating health information and digitally. And so it's there's the new fire systems and everything else. So the things are being standardized and whatnot. So now, how do we do that? How do we cut through that you know the thickness of privacy and have the impact with AI that we know it can?
Well, one of the things here in the United States is that you have information systems that are disparate. You have HCA, you have, oh my God, so many healthcare systems.
Right.
And even though we have the FHIR network to be able to communicate with them, most of them still want to keep their information separate. And one of the problems is when you have, in every culture, you have too many people with the same name. And as you get older, you have medical information in 5 locations. How do you actually make sure that the information in that record is really your information? And in the UK, I know is it a single system that is a single data system that's managing everybody? Because I've had people that said they lost their MRI. They had a test and then they couldn't find it.
I wish, Jose, it was a single system and that, that tracked you around the nation as you decided to go on holiday or perhaps seek care in a different organization. Unfortunately, the system is still very, very fragmented. So if I was to use the example of the NHS, which is one organization with many separate little trusts, or I say little, but large, and the information doesn't necessarily flow from one place to another. So you might have your data captured in one EHR for one trust, which can have a large geographical footprint, then go on holiday, I don't know, 60 miles across the country and find none of that has traveled with you. It's not something that has come. And so if you didn't bring your medication or you don't remember, say for your loved one, what medication they take or what their medical history is, then you get stuck. And often it becomes the GP, the general practitioner, that becomes a single source of truth, which is then a very manual process. So I, as a physician, have spent so much time on the phone to general practice or GPs trying to take calls saying, okay, is this in their history? Or the patient's telling me they're allergic to something, but they can't remember what, and they're, life-threateningly allergic. And so these manual processes in that fashion, they lead to a huge amount of inefficiency in often a really burdened system as well, which leads to burnout, it leads to patient frustration, and it feels like it just doesn't need to be like this. How much time would we get back, the patients would get back, And often the patients expect it. They'll walk in and say, "Oh, don't you know that already about me?" And you're like, "No, I'm sorry, they don't. I don't."
So
um,
when a patient goes to log in at a hospital, and let's say you have information at three locations, give us an understanding of what the login process is for a patient.
Okay, so I mean, again, hopefully anybody listening, there are. I'm going to caveat my answer by saying I'm sure that there are anomalies to this rule, but in general, you're going to turn up, you're going to book in at a reception. They're going to ask you your name, your date of birth, your address. You have to schedule, book all of that. If you've never been to that organization before, if your GP records you haven't so your primary care records, you haven't provided consent for them to be able to release that to secondary care within that sort of geographical area, they're not going to have that information already. So you're going to go in and book in there and start from scratch, really. Now, you do that in one place, and then, I don't know, you're visiting your mum, you have a fall, and you go to the local A&E or the ED, as you guys call it, same thing again. So it's a huge amount of impact in the sense of like administrative impact, but of course the clinical information that we're not seeing, that's not traveling with the patient. So again, you're starting from scratch and then making the best clinical decisions that you can make. The question is, would you make a better decision if you had more information?
Of
Yes.
course you would. Yes.
Yeah.
Well,
Eric, what was your experience in that regard? Because you had some problems with identity.
Well, my problem, I mean, honestly, the HIPAA prosecution that I facilitated back in 2004 was before the standardization of medical records, and things were still somewhat manual. I mean, when I walked into and this was at all the hospitals I was treated at I had leukemia and was bouncing around to hospitals around the country, really. And every time you would walk into the facility, even a facility that you're seen at on a daily basis for a year, every time you walk in, the receptionist would say, "Okay, what's your name, date of birth, social security number, whatever." And they had a printed out sheet right there with all that information on it. And then once they check you in, that sheet just gets tossed into the wastebasket, and it's got everything on it that you would need to steal someone's identity. So even though HIPAA had gone into effect in in January 2004. And by the way, the identity theft that happened to me from a hospital worker taking my information and opening up 20 credit cards in a month happened just a few months before that. So, yeah, it was just right on that timeline when HIPAA went into effect, and it hadn't really been taken seriously yet. I mean, things have come a long way, but it also has put an impediment into care, as Angie mentioned. So,
So what we're talking about is that there's a very broken system with regards to maintaining your information in a master location that then gets aggregated from the other different locations. So this is where we need AI to actually have a master global ID that then connects to your other IDs in multiple locations and have the AI sift through and create your master medical record, where all of a sudden you have one location that they're actually accessing. But the fact that, you have, and I've seen in some hospitals where all of a sudden I just had an X-ray over here and now they're gonna, they don't have access to it. They're repeating the tests and
oh,
they,
it happens a lot. Yeah,
yeah.
happens a
Yeah.
lot.
yeah.
Repetitive, redundant, and a lot of wasted expense. I mean, I can't tell you. I would say probably two-thirds of the medical care I received when I was going through 2 years of inpatient treatment was redundant and unnecessary. So every time you saw a different provider, they would run the whole gamut of tests over again because they just either couldn't access it or trust it or didn't, mainly access, right? So yeah, I mean, we have these technologies, blockchain technology, login technologies, secure logins, things like that that do not have I mean, we need to move beyond passwords. We all know that. So I think we're headed in the right direction. But you're right, Jose. We need a central access point that patients and their providers know they can access all the historical information for that patient.
Yeah, I
Well,
was just going to say real quick, Jose, real quick on that, Eric, was, the issue I think, and Angie mentioned earlier, was, the access point of those EHR systems is such a closed system. I mean, you got here in the United States, you've got Epic, and Cerner Oracle are the big two. You have some other ones like Allscripts, et cetera, but those are really the big two. And Oracle Cerner is trying to keep it more of an open architecture, whereas on the Epic side, they strictly want to keep things very much locked down. So the ability to move those records back and forth between one hospital system and another, or one practitioner to another, is very, very hard to do. And even with AI, there's still that element of how are they going to structure it? How are they going to set it up? How are they going to make those systems accessible across that patient journey? And right now, it's still a fragment of unfortunate errors.
I do want to point out that AI is only as good as the source data, right? So AI is going to do nothing for us as far as let's say for example, advocating for a patient in the sense of using AI to map out what would be the optimal clinical studies for that patient. Okay, so just that as an example. If you don't have access to all that data in one location, and that data is not in a clean format and parsed and everything else, the AI is going to be worthless, right? It's not going to be able to look at everything. It's not going to be able to consider all of the factors that go into that patient's care. And
Yeah, there's a couple of issues that are coming up here. I mean, the first one is identity. The second one is data flow, which is obviously linked with the identity of the patient, but it's almost a separate issue in of itself. And the third piece is actually, can the systems can they be designed to talk to each other? So the identity piece and the data actually flowing, they seem slightly separate but interlinked. What are your thoughts on that, Jose, given your experience?
Well, what's really fascinating is that when you have a database system that you look up Mary Jones and 10 of them show up, that's really a problem, right? So as a patient, you have a different ID number at every location. So the current systems for patient record matching are really not enough. The error rates, again, you wind up having accidentally a record that was put into your medical record that wasn't yours, and that's really a problem. Apparently, it takes 18 months and $18,000 in 18 months, something similar to that, where it's expensive. The EMR systems are similar to blockchain that you can't erase them. It's crazy. In the AI world, AI has just exploded incredibly. And one of the things we're worried about is that they're logging in with a username and password. And it's one thing to use AI in healthcare when you're analyzing some chemical processes. It's looking at a microscope or it's looking at X-rays, and the system is actually evaluating and giving you a differential diagnosis, or so that's really kind of cool. But the problem is that logins are very insecure. In fact, right now, Google just sent out an article. They want everybody to stop using passwords. And things like, yeah, the AI world, you're logging in with things that are so insecure that the entire criminal world is now taking advantage of the AI. The cyber attacks are now increased 10x with AI. So it would have been one thing to give it to the good world, but not to the bad world.
Yeah. So, I mean, how does one tackle that? How do you go about that?
Well, we've got a solution that I don't really want to go into right now because this isn't a marketing. This is more to discuss what we're doing. But the Nimbus-Key ID system is a patented solution in which we do a true user verification, and then you do a secure backend connection to enterprise systems with SAML2 or OIDC, which is what the banking industry uses. So it's a secure connection. Each user gets a unique universal ID that will then be the master ID to connect to other data systems and your accounts with those systems. And then to log into those systems, we issue a dynamically encrypted ID and a QR code and PIN. And those are the new login keys that change every 5 minutes. So criminals can't steal them, can't reuse them, and even quantum computing can't decrypt them in 5 minutes. So,
it's
so
pretty
we're
cool.
really focused on protecting systems.
Yeah.
Eric Doherty, the AI world in your end in healthcare, give us a little understanding more deeply on the types of AI that's being deployed in the healthcare system.
Yeah, actually, great timing on that. Actually, the FDA just approved last week the first AI medical device in actually diagnosing breast cancer. Don't know if you all saw that, but that was pretty neat to see. And really, I think as we're moving along, there's a lot more activity that's happening with AI in that healthcare setting, both in the digital framework, but also more and more on the medical device side. What we're also seeing is on the clinical trial side, and as Eric Drew mentioned earlier, the use of AI in clinical trials, drug development is at the forefront right now, just because of the use of the data, the ability to use digital twins, and the ability to take information much more rapidly than had been used before. So that's a huge win-win, I think, for everybody around the world, which is pretty awesome. The other part is really the patients that are kind of the low to the middle income patients who not necessarily had the aspect of access to healthcare directly. I think a lot of what's happening with AI is the ability to maybe tap into monitoring, tap into telehealth services, tap into other elements of those areas where patients, cannot maybe potentially afford a typical insurance carrier, et cetera, where they've got some avenues now where they can potentially use AI to drive some of the initiatives around healthcare and healthcare treatment, which is pretty awesome. I think last but not least, I think the kind of biggest tell that we're seeing with AI is that more and more people are becoming more comfortable with using AI, both from the corporate world, but also just from the personal setting. I think as we're moving forward and seeing more and more of it being used, the corporate world is using it, I would say, at a clip of about 30 to 40%. The personal realm is about that same element of percentage. And so that's going to be a huge win for AI to be used in healthcare treatment going forward.
Cool, thank you. Angie, tell me a little bit about your experience of the way that cancer patients are being managed in the UK and the positives and the negatives, and maybe what you would like to see advance in that regard.
Yeah, thank you. Cancer care in the UK, I have to say, is excellent. We have a huge number of metrics that we are very protective of keeping to. It's very patient-centered. Of course, this is the majority of the experience that I've certainly had. I think tech really brings a new element and facet to a disease that can be totally life-destroying, not just for the patient, but their whole family as well. So my personal interest is in early disease diagnosis. And I think we've got a huge amount of scope, not just in diagnosing early disease, but treating early disease as well. And there's so many treatments in the space now, more being discovered with the use of AI, with great partnerships with pharma and clinical trials. Access to clinical trials, even in late disease, is hugely improving now that you're essentially getting all the huge amounts of data that's put in front of us as physicians and oncologists, and then helping them to digest it. So it's sort of human-centered care, but with enhanced tech capabilities. So there's so much to talk about in the space. I think it absolutely will transform the care that we are able to deliver. My hope is that there are fewer and fewer patients diagnosed late in disease, and that becomes a real rarity and not so accepted as it is today. And we can then even start to move or progress in the prevention space as well, with a lot more evidence and evidence-backed care as well in that space. So I think care in general is transforming, and that will be, of course, it will hit cancer patients as well, but giving the ownership back to the patient. I've heard the term the patient as the CEO of their care, where with tech, you're giving them tools to be able to manage their health, and they're not reliant on somebody in an office spending 10 minutes with them and explaining this and that. So you're really giving that ownership back to them. You're giving them methods in which they can monitor their disease potentially with some autonomy. And so I think the future is really bright. I'm really excited to be in the space.
With regards to actually keeping people healthy, I want to make a couple points. In the United States, and I'd like a comparison with the United Kingdom, the United States, perinatal mortality and morbidity, we're 56th in the world. We're not first. Sweden is number one. The second point is that the health of the citizen in the United States has gone down so significantly that again, our longevity curves have fallen off the graph. I mean, we're living like 5 years less than we were 20 years ago. So the average, 5 to 10 years less, which is not good. A lot of hypertension, obesity, and all kinds of problems. And then we've had things that have come out that the treatment of cancers extremely expensive. People that have stage 4 cancer and they're being told that they're going to die, and all of a sudden we're seeing something called ivermectin that
Mhm.
comes in, and all of a sudden these people are now cured. And what we're finding is ivermectin apparently is attacking the the cancer molecules in such a way that it actually blocks. They have a block that prevents the immune system from attacking them. But apparently, the ivermectin, an antifungal, drug for animals, which is now being allowed in certain states to be. In the United States, there's several states that are now authorizing to be over the counter, and the number of reports that people have been cured after having stage 4 terminal cancer within 3 months has been frightening to think. So what it's doing apparently is protecting or removing the protection of the cancer cells where your immune system can actually attack it. Compared to when you're actually trying to kill cancer with other drugs, you impair the immune system and you kill the drugs. You kill the cancer with these drugs that are really quite toxic, and then your immune system can't really effectively actually continue with the attack. So there's some interesting things here. And in the UK, how does it compare with, I mean, the healthcare? It's not all fun and games, you know? You're making it sound like everybody is cool and great, but it's not like that. People
No.
are dying.
You're calling me out for being an optimist, and you're quite right. But listen, I am an optimist, and I stand by that. I'm not saying the system is perfect by any means. That's why we're putting our heads together
Yeah.
to try and make it better. But what I'm saying is we have more tools and more access to potentially evidence and backing these what might be crazy theories. And instead of using just patients as guinea pigs, Eric mentioned digital twins and other capabilities when you're looking at designing clinical trials and research studies and being able to discover drugs that we haven't discovered yet. So I'm not saying we're going to get there tomorrow, but what I do feel is the sense of the tide turning, where we were very reliant on, okay, if the evidence isn't there, we can't, medicine, as you know, is an evidence-based specialty. I'm not just going to try a drug because I like the sound of it or it makes sense or anecdotal evidence. But now with tech, we have the potential to really test hypotheses in a more controlled fashion and more explorative fashion. So that's really where my optimism comes from.
Well, what's interesting is, again, I've delivered over 8,000 babies and done thousands of surgeries as a doctor in practice. And when children were delivered 30 years ago, the incidence of autism was extremely low, 1 in 2,100. And today it's 1 in 31. And what I noticed over the years is the number of vaccines that were being given to children was increasing at an alarming rate, and now they're finding that it's associated with the cause of autism. And we're talking about mRNA vaccines that aren't even being properly tested. So there's some scary things that have been manipulated in causing a supposed improvement in healthcare, but in reality, it's causing some massive harm. So right now here in the United States, we're actually, Mr. Kennedy actually is in charge of actually changing things, making sure that our food is healthy, and the way the farming, the massive BlackRock and these boys are buying all kinds of farms and everything's automated and not healthy, not natural. The food isn't, it's so anyway, we're looking at a new way of actually enhancing the healthcare delivery, the preventative health with better foods and making sure that our drugs are made in the US and that you're properly testing them. And we have to get rid of mRNA vaccines. That is frightening.
Yeah.
There's some crazy things that are coming through the pike, which is really frightening.
I
So,
mean, yeah, our
okay.
friend, on the Huberman podcast, Andrew Huberman, if I may call him out or shout him out, calls it Medicine 3.0, which is really a new generation of medicine where we're recognizing factors like environmental factors or diet, or actually really how are we designing specific vaccines, what really is the pathophysiology, not just, oh, we've got this data to prove this. So I think we're being more explorative. We're asking harder questions now because we can.
Right.
So I think it's a new generation of medicine. Um, that is my hope.
The old term
That's
would
the
be
optimistic side.
a holistic approach to healthcare, right? And getting back to the real purpose. When I do my presentations, I talk about, we need to get back to the real purpose of healthcare. The real purpose of healthcare is what? It's to increase the longevity and quality of life. And if it's not for that, then what is it? I mean, if it's all for profit, or if, these other factors are, but it should be about longevity and quality of life first and foremost. And I think we are getting back to that. I'm very optimistic as well. Thank you.
Eric Doherty?
Oh
Yeah, I
yeah.
was gonna say I'm the third optimist on the call. I think where I see a huge win-win, and Angie kind of mentioned it around the oncology treatment, is again going back on the AI side. You look at imaging data, and if you're able to basically take ongoing imaging from a patient's tumor as an example, and see it shrink with a certain medication, or on the flip side, see it grow and they're on a certain medication, that medication is not working for that patient. And so the aspect of using AI to basically say, hey, this drug works with this patient, this drug does not, and in the future, obviously, benefit that patient and hopefully get good outcomes of no cancer for that patient. That's a huge win-win for the system. The other side of it I see is, again, on drug development and the ability to take AI and really move quickly in developing drugs for certain diseases, certain rare diseases, certain pediatric diseases, where the need to really come to market with a drug that works, the drug that is safe, a drug that is obviously effective is a key element. And hopefully through that, then will be, hopefully, fingers crossed, optimistically, lower costs. And so, the end result being better outcomes for patients around the world, and obviously keeping the cost down for those patients as well is a huge driver for me and being an optimist.
Okay, guys. Well, thank you very much. I think we're coming to the end of our podcast here. And to the rest of the world, we're inviting leaders in healthcare, banking, and AI to contact us because we would like to discuss the latest advances. And again, the digital world, as we said, is under attack in all verticals. And we need to be able to protect this in a way that advances our future in a positive direction. So information is important, and we're here. And Angie, thank you very much for being our guest. And everybody, have a fantastic day. Thank you very much.